Hi everyone, I'm Cheryl Chuda. I'm the school nurse for Fall Mountain High School in Langdon. I'm also the chair for the Continuing Ed Committee for the New Hampshire School Nurses Association. We're really excited to have two phenomenal speakers tonight to talk about vaccines. We have James Potter, and I will give him a nice big long speaker bio. And we also have Dr. Talbot, who is near and dear to our hearts. In case you didn't know that, Dr. Talbot, you have a lot of groupies when it comes to the New Hampshire school nurses. Before I introduce our speakers, I'd like to take a few minutes to just welcome everyone and give a huge shout out to Pam Clay Storm. Pam Clay Storm is a school nurse at Conant High School in Conway, and she is the one who has arranged all this. She actually arranged this talk for her staff and thought of all of us at the same time. So Pam, we can't thank you enough, and I personally can't thank you enough for making me look so good month after month. So without further ado, I don't want to waste anybody's time. James Potter is the Executive Vice President of the New Hampshire Medical Society. He served as the Executive Vice President since 2015. He previously served in senior management and advocacy positions with the American Medical Association and national specialty organizations, including radiology, pathology, and physician's assistants. Jim has been awarded the FDA Commissioner's Special Citation and the Vice President's Hammer Award for coordinating a consensus approach on federal quality and coverage guidelines for mammography. His advocacy work has been recognized by the American Society of Association Executives with its highest honor, the Summit Award, for advancing early detection and intervention for children with hearing loss. While at the AMA, he helped to establish multi-specialty initiatives such as the Relative Value Update Committee and quality measures development under the Physician Consortium for Performance Improvement. Jim received his graduate and undergraduate degrees from the University of Michigan. He is an avid New England Patriots fan. Yes. Enjoys playing golf and hiking with his dog, Harry. Jim lives with his wife, Karen, and their 4 children in Concord. Thank you so much. And again, we have our Dr. Elizabeth Talbot, our infectious disease specialist. She's a deputy state epidemiologist and infectious disease specialist. As I said, she graduated from UMDNJ Robert Wood Johnson Medical School in 1992 and is affiliated with the medical facilities of Dartmouth Hitchcock Medical Center and North Country Hospital and Health Center. And we all know her as our favorite, one of our favorite epidemiologists from our own Department of Health. So I will stop babbling and let you go ahead. Thank you.
Thank you very much, Cheryl. Appreciate the opportunity, everyone coming on later in the afternoon here. Brian, next slide, please. This is all part of an effort we call the New Hampshire COVID Vaccine Alliance. And our efforts, our mission, and this is a mission and goals we developed with the Division of Public Health Services back in November, kind of looking ahead of how could various stakeholder organizations come together to help promote vaccine confidence, support accurate and consistent vaccine messaging, and then help foster the coordination of the vaccines allocation process. And our goals are to promote public buy-in for the vaccines, to increase immunization rates in New Hampshire. Most importantly, really to act as a force multiplier to support both the vaccine communication and allocations plan from the Division of Public Health Services. Also to counter misinformation when it happens. And we're also going to be working later on to help foster New Hampshire's immunization information system. Next slide. These are our sponsors who have helped us, with the contributions. So free up my time, free up some of our resources so we can kind of do this type of thing. We've been meeting weekly since mid-December. We gather, we've had audiences anywhere from, they usually average about 100, they go up as high just under 500. And you're all welcome to attend those. We'll have information afterward if you'd like to ongoing to participate. Next slide, please. Dr. Talbot's going to really kind of get into helping with the questions. What we're going to do here first is kind of go through a couple of things of why you as school nurses are key influencers in the school's community on vaccines. And two, what are the challenges and primary drivers of hesitancy? Also go through some vaccine messaging, kind of do's and don'ts. Talk briefly about the FAQs that I'm hoping you all have a copy of and can use in your schools, and then we'll go into Q&A with Dr. Talbot. So next slide. So this was a study done in December by the U.S. Ad Council of about 20,000 individuals. And what it really points to is that those in healthcare and are in communities are really the key influencers here within communities. So I know I've been talking to some nurses and kind of heard, well, I'm not sure if I feel comfortable in doing this. And the answer is yes, you can. People will look to you. And so by you being in schools, you are the direct source of folks who are going to turn to you for questions and answers. And you can see that, you know, other important figures like the president and mayors and employers rank way down. So you're the key influencer from this research. And that's why we need you to help us do this. Next slide. So hesitancy is complex. There's many factors: fear, distrust, confusion, misinformation, and we'll even get into complacency. But the concerns are really about safety and side effects. Some are also driven by the speed of the clinical development of these processes. But more importantly, it's really the lack of knowledge and how can we communicate some complex issues in kind of plain English that folks can understand. And just keep in mind, there's still, you know, a heavy distrust of kind of the political environment and economic motives. And that's why you kind of saw in that survey that you don't trust necessarily corporations or employers or even a government that they don't know. Next slide. So in talking about messaging, the key thing is really to lead with empathy. And I know my mom was a school nurse, so I know this is what you do every day. This is your strong point. So being welcoming, personal, authentic, and most importantly, respect the hesitancy and knowing it's okay to have questions as you're moving forward. Try to avoid negative or guilt mongering as you're presenting or you're hearing folks through. And the most important here is really provide scientifically based answers in plain language, if at all possible. Also remember that emotional triggers are important here. And moments that have been missed are very important, kind of powerful reminder of what our goal here is. And it's the emphasis. It's, you know, from you, it's you're protecting yourself, your loved ones, and your community. So you can speak from your heart on that to help instill kind of those emotional triggers to help minimize hesitancy. And mostly, as I kind of mentioned in the beginning, folks want information from health experts that are locally placed, and that's you. Next slide. Here's some things that don't work. Fear tactics, generating trust about people. You're really trying to answer questions about the vaccine. The other thing is guilt. You know, I think the research that was done by the Ad Council indicates that more people are worried about being guinea pigs than free riders. And make sure that you state the facts as they are. Don't try to sugarcoat them, overpromise. That leads to more hesitancy. And really, this is more about getting back to life rather than back to normal. As we develop as a culture, the way we did technology 10 years ago wasn't normal. That's not the normal now. And so as we go through and pass a pandemic, there'll be a new normal. but it's really getting back to life, those things. I mean, I think those who got outside could see, everybody, it's in many parts of the state, it's north of 55, 60 degrees, and people are going, I get back to some of life from the wintertime. Next slide. So I'm hoping that you have a copy of these vaccine FAQs. We provided them in both PDF form and in MS Word. So if you want to take these and you want to modify, you want to add a new question, you have some ability to do that with these if you'd like to do it. And so the questions, we'll talk about that and we'll ask for your questions. So as we get into the discussion part, we'll be relying on your questions. So please use the Q&A function on the bottom part of the screen to ask your questions. All the panelists will get these questions, and then we'll try to answer those that you might have. Next slide. So we're kind of now moving into the questions and answers period. And thank you, Dr. Talbot, for joining us. Last thing that I'll mention here is there are a couple other education tools that you might, all the information that I just discussed was distilled from the Ad Council's Vaccine Education Toolkit. So that's a great one. There's other graphics and things. And then the CDC also has a website on how to communicate with school staff. And so that's another good area for you if you want additional information. And I believe Brian has just put those up. Our technician has just put those up on the side. So if you'll click on those, you can go right to those documents. And so, Dr. Talbot, welcome. Would you like to elaborate on anything in particular? You want to talk a little bit about the vaccines to start off?
I would first like to congratulate you on a wonderfully succinct, clear presentation on a complicated topic. So I learned from things that you've just said here, and I also really enjoyed reviewing the FAQs, which I think are actually quite spot on. So I think that if this group asks, has the time to review those and promote them, I think we're all going to be in a good place. So I think that there's some overlap in audiences between our Wednesday afternoon school call and this audience. So I run some risk of repeating things that you've heard in both, but one comment is we're in a really great place with regards to vaccine supply, and things are moving so fast, right? We're getting more vaccine than we expected. We have this third presentation now, the Johnson & Johnson Janssen, and our state is benefiting from years of planning for just this kind of event, where we have partnerships and we have mechanisms that are really working for the people of New Hampshire. This school audience, of course, is well aware that our timeline has greatly come forward for access for you. And I keep hearing on all the various calls that I'm on from state leadership and knowing the numbers that we have, that the mantra for everyone, what we need to tell one another is that there's going to be enough vaccine for everyone in a short period of time. We are all very steep on the learning curve of these vaccines, of course, because they haven't been with us very long. But I hope that your questions today can help you overcome any hesitancy you have, which I think is one of the key ways that you can help others overcome their hesitancy. So those are some preliminary comments that I'd make and say I'm very glad to be here with you. I very much feel as though I'm an evangelist for this vaccine campaign in our state. And if that wasn't clear already, I think that's going to emerge as a message I hope you take away, that there's a lot to be excited about and a lot of good things happening with our epidemiology and access to these very effective vaccines.
Thank you, Dr. Talbot. So there's a couple quick questions of where you can get these. And so both sets, the MS Word and the PDF copies are part of, have been given to the association. And so I'll defer on how they can best transmit to those. But what we can do is we can also make sure that we'll have those by tomorrow morning. We'll have those and the presentation that we just that I just gave today, I can make sure that they're on the New Hampshire Medical Society's website, and it'll be usually new events or new information, and we'll just put links to those documents for you if you need them or if you haven't gotten them yet. But and also why I'm at it, once you can take that presentation and you can be evangelists. You can talk, and you're leaders in your own communities. So if you have other local communities that you can present to, other civic organizations, you can kind of give this kind of talk on trying to influence others to be able to, or just present information and be a resource in your local community for those even outside the school system. But we know that in the next week here is when we're really starting up to have the allocation for phase 2A. And so this is your great opportunity. Those will be both in closed pods, and as was mentioned by Dr. Daly just a few minutes ago at the governor's press conference, the majority will be going right through the what they call the VINI system. It's the same thing that those in phase 1A were doing, but it's a state-run system to register. And so they'll be starting with you all and being able to register on that site. And I believe that's the 17th. So I think that's next Tuesday, if I recall. Right? Maybe Dr. Talbot can correct me on that.
Yeah, well, the 12th is the key number to remember, which is what, tomorrow, where our PHNs are beginning. The regional public health networks are beginning their processes. The 17th is registration through the usual points of distribution methods, the fixed sites, as we sometimes call. And then those appointments start to put vaccine to arms on the 22nd. So it's all happening very fast, very exciting.
Here's a question for you, Dr. Talbot. Do you have any thoughts on timelines for school-aged children being able to receive the vaccine?
Yeah, sure I do. Watching this data really closely, that children do get this infection, but less commonly than adults. They get sick, but not usually as sick as adults, and they transmit, but not generally as effectively as adults. So they are a very important population to consider, and all the vaccine manufacturers have stated their plans to roll out safety studies. Some are underway, some are yet to begin, in order to show safety in younger and younger populations. These studies won't take as long as they did for adults, and even those went pretty fast, I think you'll recall. So we're expecting probably full access, at least by school start in the fall.
Right. Another question is there going to be which vaccines are going to be available to teachers in phase 2A?
The Moderna vaccine, an mRNA vaccine, the Pfizer vaccine, the other mRNA vaccine, and it's likely that there will be increasing access to the Johnson & Johnson vaccine. I think that this audience has been paying close attention to the platforms that these vaccines are in, that is the mRNA and how that works, and also the Johnson & Johnson, which is a vector vaccine. With a track record that's excellent against Ebola, but there is not a robust supply to date. I would also let you know that we're told Novavax, the next Operation Warp Speed vaccine presentation, is likely to come to us in a similar fashion over the next weeks. They've promised their phase 3 will be completed during the first quarter of this year, and that's coming up soon. So we may need to accommodate 4 different vaccine presentations in the coming weeks and months.
More specifically, in talking to some of the allocation staff, the state is not likely to have the Johnson & Johnson or the Janssen vaccine in ready supply. So if we had to bet probably over the next 2 to 3 weeks, it's likely going to be one of the mRNA vaccines. So it'll be the two-dose regimen that probably most of 2A will be getting at this point, unless there's, the federal government kind of changes its mind and we somehow get more supply. But I don't think that more supply is going to be likely till at least the end of the month.
Well, we have 5,300 doses for this week in J&J, and we're looking at indication that there may be some additional next week. It's really dynamic, and one thing that I'd like to stress, as it's often a question about which vaccine is best, these are all three highly effective toward severe illness, preventing hospitalization and death. So whichever presentation is offered to you, I'd like to strongly encourage that you take as soon as you can, especially as it seems to me very clear we're in a race against the variants that are emerging pretty quickly in our country and globally.
Great. Are you aware, the next question is here, are you aware of any pediatric clinical trials being conducted in New Hampshire, which are looking for study participants?
I simply am not. I knew that AstraZeneca was studying those 16 and older in Portsmouth, but I'm not aware of the status of their enrollment. I think they've completed enrollment.
Okay, and the next question here, I'm going to just read this. Our district is struggling with how best to present to our school staff about voluntarily providing documentation of their vaccine status, so we can confirm if he or she needs to quarantine due to exposure for travel. Any guidance or recommendations on how best to proceed? We don't violate HIPAA. Is there a written template to guide school districts?
So, yeah, I'm trying to think through the different asks within this question, which is first, perhaps, is it enough to trust someone with what they tell you regarding their vaccine status and their need to quarantine? I hope so. We've never been in a position to have these immunity passports, which were so commonly spoken about in early days. And there are issues of HIPAA and confidentiality with regards to what medical indication might have brought them to vaccination, for example. So I'm not aware that there's any support toward making it a routine to request vaccination proof. So that's the first reaction I have to your somewhat challenging question, if you will. So I'm not sure if Dr. Potter has anything to say on that either.
No, I think when everyone will be given, typically as you come through, you'll be given a card, particularly with the first day of your dose, type of vaccine that you were given. So you'll have some information in hand. As this is, there you go, right? Exactly like that. Thank you very much for the graphic. I love it. No, I don't know anything else. So the next, go ahead.
Just one thing to follow on this, by the way, which I certainly don't understand why they have 4 lines of being able to write which vaccine you got, since we don't have a 4-dose series. But let me leave that. I suggest to people, once they've had their card filled out, that you take a picture of it. You send it to your provider so that they can put it into your own medical record, and that serves as a duplication if you should travel internationally to a country that's requiring documentation or otherwise. But just in terms of the writing on the wall in New Hampshire, I'm not seeing any strong momentum toward asking people to prove their vaccination.
That's an excellent idea. The next question is to register for the regional public health networks. What website will they be going to tomorrow? They actually, the short answer is that will be conducted through each SAU. And so if your SAU is working with the Regional Public Health Network, then you'll likely be getting email from your superintendent on the instructions of what days that will happen and where it's going to happen. But typically what SAUs are doing is they're choosing one site in the school district for everybody to come in during the clinic. And I think how those are going to be managed are going to be dependent upon both the regional public health network and the school district.
Sounds quite right.
Go ahead.
Yeah, and I saw the next question. Is there county data on age breakdown of cases? And I hope you don't mind if I just take an opportunity to share screen and show you some fun things that are happening in our dashboard. So I hope this is familiar to you. I myself turn to it multiple times when people ask these kinds of questions. So this is the homepage for us. This is the dashboard. And I think trends is, of course, interesting to see where we're at in this epidemic in our region. And within that, you can filter by age. So for example, if you're interested to know what about those who are 0 to 9, then you can see those numbers come up too. So lots of different ways to play with this data, but I would suggest that these numbers in children may be falsely low, given what we hear of persons who are reticent to come in for testing, and also coupled with the biologic fact that children often are asymptomatic or very, very mildly symptomatic with disease. So those numbers are available to you though. And there's other new tabs. If you haven't seen it yet, you're probably really well familiar with the school tab. We now post hospital data to show the rate of hospitalization and what's going on with bed capacity in our state. And well, I guess I stopped share too soon. Do you mind if I show off the vaccination one? Because I think this is pretty fun for us. Right now it's quite basic, but this is the way you can track what's going on over time. So we're doing well with regards to our first doses and then second doses. So there's lots of different ways to track the national progress. And just to make comparison, we're doing as well or better in terms of the amount of vaccine we receive and the amount of vaccine we give. So the proportion of our population that is vaccinated is really growing nicely. So again, I'm trying to craft this theme that things are finally looking up for us. So this is a good direction for this particular graphic to be shaped as opposed to our epi, which we don't want to see in this particular shape.
And here's another clinical question. Do you think people will need to get a booster yearly, like the flu shot? Is that there always great compliance with people getting the flu shot? So concerned about people who won't maintain their COVID vaccinations.
I'm sure you have some thoughts about that too, Dr. Potter. I'll take a first swing and then you can fill in what comes to your mind. First, there's a couple of places that boosters are going to come to us, I think, and one is through the Ensemble 2 trial, which is the Johnson & Johnson Janssen vaccines study looking at whether the second dose might increase the overall efficacy of a vaccine. That's coming very soon. And it might be that we need to tell everybody who went to the racetrack over our 3-day super site event that over some period of time, they would do well to come in for that second shot. That's maybe a different issue than what you're asking. So for example, the mRNA vaccines, we hope they're at least a year. We hope they're a little longer. I've heard that both mRNA vaccine manufacturers are co-formulating with influenza, suggesting they think that it might be an annual. But we really need to just wait. I suspect this isn't going to be lifetime protection, but what that interval will be, we just don't know, and I think nobody knows.
No, it'll be interesting too, I think, with variants and if various kind of mutations that happen, if the vaccine manufacturers take a tack like they have with the pneumococcal or measles, where you have essentially the vaccine provides against multiple strains or multiple variants for COVID. So I think that's something we could potentially see down the line too.
Yeah, no, that's the great aspect of this conversation is I already framed it as we're in a race against the variants. I would like you to have some talking points that the most prevalent variant in our state and in our country is that B.1.1.7 that you've heard so much about. And it does look like the mRNA vaccines are fully protective there. There may be some compromised efficacy for the what people call the South African and the Brazilian strains, the B.1.351 and the P.1 strain. So let's break these chains of transmission before those get into our country and become prevalent. Yeah.
Back to kind of the question about documentation. Can a school district require that you provide documentation and staff need to comply with this?
That's the question for your lawyer and for your counsel. The state of New Hampshire will not mandate this vaccine, especially while it's under an EUA, that is without full approval. And so it's really a legal and not a clinical question, I'm afraid.
Right. And I would say we can't mandate that anyone take the vaccine.
Right.
And so we, through this, and we're hoping you as influencers can get as many as possible. I think, though, we'll have multiple attempts to do it. So if your school district has a closed pod and they go over a couple of days and we have some people who don't, we'll still have the option within a few weeks of that and later on to get the vaccine. But our emphasis is really to try to get as many people as possible up front as part of that. Remember, this is a 2-dose vaccine, so it's going to take, your second vaccine is going to be given about 21 to 28 days later. So this will be occurring over, when we start by mid-month, it'll be occurring probably through, I think, through April before we conclude with the 2A on the second dose. Go ahead.
Just that we're really close to also overlapping with our 2B population, excuse me. So those who are 50 to 64 are going to be brought forward quickly too. So again, lots of efforts afoot to meet people where they are. We always have a priority for making sure that those who need special mechanisms for access for purpose of equity, those who are more vulnerable to disease are also reached in these next weeks and months.
Great. Thanks for the feedback on not being able to hear me as quickly as Dr. Talbot. She's just more articulate than I am, probably, and has a better speaker system than I do that I'm using right now. But thank you for that. I'll try to speak up and I've amped my my speakerphone up a little bit too to that. Next question here. Do you feel in the fall there will be times to quarantine or isolate?
So great question. Excuse me while I reach over for my crystal ball. I don't know. I just don't know. Do I hope not? Sure. But what's the model here? What's the new normal? As Dr. Potter mentioned earlier, are we getting back to the way it was before, or are we adjusting to this emerged pathogen as endemic that is part of life on planet Earth? And I'm afraid it might be that latter, where people might elect to continue to wear masks, especially if they have medical vulnerabilities. People may find themselves as part of a cluster, a super spreader event, as people used to call. Like, think about what happens with flu. Usually, if a flu case happens, the health department doesn't put those contacts onto quarantine unless they're in a really vulnerable setting, like a long-term care facility or such. So I think that might be how it's going to go, but boy, check back in with me in a year and then we'll laugh at my naivete or whatever is informing that answer.
Yeah, my hope is that in the latter part of the summer, if the supply is up, that we'll be able to start targeting college age individuals, of course, anyone, and probably those, hopefully the studies will be able to come forward where we can get maybe into the teenage group. So particularly those in the high school years. That's my hope by next fall, but at this point, it's only a hope, depending on a lot of factors.
Yep.
So here's a good question. I have people hesitant that they are concerned of the late effects from the vaccine on their health, such as cancer or other health effects later in life. How would you answer this concern?
So I was waiting to see if you were going to take that tough question, but in the absence of that, I will stumble through, and then you can add to it. No, it's a really, really important question, and there's lots of things I actually want to say to you. The vague concerns that people have related to the fact that this is a new type of vaccine, the mRNA vaccine. Sure, that creates unknowns. I like what you said earlier. Don't sugarcoat it. It's new. We don't know everything we want to know about it. But I do follow the data closely, and I'm very reassured to know several things. One, the platform has actually been around for decades, right? This wasn't invented last month or year. This has been studied now for several decades, 2 decades. So we know a lot about it. We also know a lot from the phase 1, 2, and 3 trials that have been done in humans that have not shown us any emergence of a safety signal over these now, this year of use in humans. And then third, I'm very reassured that people who are a lot smarter than me have not found a plausible mechanism with which they would predict that they would cause reduced fertility or cancer or early onset something or other. You know, I think that there's just been not a plausible cross-reaction postulated. I think that when people bring forward what start to sound to me like conspiracy theories, you probably all heard the Bill Gates putting microchips, or this is some sort of eugenics, or some kind of way that we can make people infertile, or, you know, just put them out into the universe and test them. You know, like keeping them as a secret only lets them fester, I think. Bring them out into the sunshine and really see what's the evidence behind them. And very quickly, you find none. And so I keep going through that cycle. There are several good websites that do that. WHO has one. The BBC has one I really like. Speaks in a real science-friendly way. New York Times follows them. CDC also has it. So look for credible sources that debunk actual myths or conspiracy theories that you're hearing about.
Yeah. To go back to the question, I think the shortest answer is probably that the vaccines do not alter DNA. They're not formulated to do that. They're not like eggs. They're developed to develop antibodies against the COVID or the coronavirus, COVID-19. So it would have to have an impact on fertility or cancer or anything else. It would have to be impacting your DNA, and that's not how this vaccine works. So that would probably be the shortest answer that I give you. And I think we have that in the talking points. The other thing is it's not a live virus. So you can't get COVID from this. So those are probably where I would probably steer you to respond to those individuals in kind of a systemic way. What are some reasons you're hearing from individuals or groups that are reluctant to receive the vaccine? That's a great question. So in our talking points that we developed with the New Hampshire School Nurses Association, we really focused on 2 questions a little bit more. One has to do with concerns by those in the schools or school employees, teachers, employees who are childbearing age. And so there's a particular question in there that's a little bit more in depth than probably where you'll see something else. And really what that it goes to, I'll rather than repeating that in full, that's a great source because I think it's a pretty comprehensive answer. I've given it to other colleagues and they go, oh, well, you've said what it doesn't do. You said this is what you have to be concerned about. And you've also put in what we do is for those who are pregnant, there's a greater risk for if you contract COVID. for both the health of your health and the health of your baby. That, and then the second issue that we were asked to focus on a little bit more was those who have any kind of allergies and what should I be concerned about. So our question there also tries to go into a little bit more depth. It also talks about if you've had a severe reaction to a couple of the elements in the mRNA or vaccines, then a little additional counseling to reach out to your physician and talk that through before. There will be procedures set up if you've had an allergic reaction, that the process is essentially you're a precautionary case, and you'll spend a little bit more time, at least 30 minutes after you're given the vaccine to make sure that there isn't an anaphylactic or other reaction to the vaccine. Dr. Talbot, do you want to expand on that?
That's great. I do think that we were watching very closely at the beginning. You remember when the UK began their rollout and there were a couple of cases of anaphylaxis, and I thought, oh no, here we go. But I want to reassure you that the very careful attention to safety that's been put in place through multiple redundant mechanisms has shown that the rate of anaphylaxis, a life-threatening allergic reaction, is approaching what we tolerate with other vaccines. So it's 4 events per million doses given of either the Pfizer or the Moderna vaccine. So it has not emerged as an important problem. That said, some component of vaccine someone may be allergic to. So the safety mechanisms in the operations of it, that is, if you go to the closed pod, will be you'll be asked to wait for 30 minutes if you have a history of anaphylaxis to other medical components that are well delineated. I won't mention them here. So bring a book, bring a friend, whatever, expect to be there a little longer so we can make sure that you tolerate this well, as most people do.
Right. Here's a good question. Any concern for school staff to have a vaccine at a pod clinic, contraindications to get a pod clinic versus their physician's office? One, what I would say, just logistics, I think getting that in a physician's office is going to be a little further out. I think it's going to be at least a month, maybe 2 months before that becomes available through the allocation process. The other thing, and Dr. Talbot is much more expert here, is I believe it was HON 36 that talked about updated the contraindications and precautions, and there was actually an appendix in there that went into detail on that.
Yeah, you're exactly right. We're hearing very few circumstances where a clinician says, I don't feel comfortable with my patient getting it at a pod, even though we have doctors and emergency response equipment there, et cetera. And they want it done under medical supervision. These are very unusual circumstances, like mast cell disease, a very rare immune disease that predisposes a person to anaphylaxis. And we do try to accommodate that. Sometimes a person does have a reaction to the first dose, and the clinician's not quite clear if it's an immediate allergic reaction, vasovagal, or just reactogenicity that you expect and even hope for. So in that case too, we might recommend having the second vaccine dose given in an allergy clinic or in a hospital setting. But these are rare circumstances. So just want to reassure you that this, again, has not borne out to be a major problem with these vaccines. And we do have redundant safety systems in place should something untoward happen.
Next question is, what should the rebuttal be to the all too often heard, quote, there is no term safety data available for these mRNA vaccines?
Great framing, thank you. And I think it's, there's no long-term safety data. What are you going to say? That's right. We haven't had COVID long enough to have long-term safety data on a vaccine against it. For me, my strategy is often to ask, are you concerned about anything specific? And then we can talk about pathophysiology or biologic plausibility or such. But sometimes when there's just a generic, vague concern, it may be useful to talk about the ways that safety was built into development of the vaccines, scrutiny at every turn, and then this ongoing, really unprecedented attention to safety during this national rollout. So I think I'd like to try to dig in to that person to find out what their fears are, like we talked about, cancer or fertility or what, and see if we can speak more specifically about that. But in fact, you're right, there is no long-term data on COVID-19 vaccines. So just being honest.
Here's more of an allocation issue question. If a teacher receives the first dose in a closed pod and cannot make the second scheduled date, how would we best advise to have them scheduled for that second dose?
Yeah, lots of mechanisms. I think you're hearing that theme too. There's lots of redundancy. We are very actively supporting lots of different places where these vaccines can be given. So for example, the commercial pharmacies are beginning to receive some just for this purpose. We have them at all the points of distribution, as you've known well, and these show online too, you can see. Private doctors' offices now have stepped up to be providers of this vaccine. So we're very actively moving the pieces on the chessboard to put it out to people so that they don't necessarily have to go to the same place to get dose 2. We understand life moves on and, things happen. I wanted to let you know too that we have a pretty big event coming for ourselves. That is, we're moving away from VAMs. Phew. So if you haven't heard that word, I hate to burden you with it, but this is the CDC's tracking method for giving doses. And we're moving to what I heard at the press conference is being renamed Vinny. So you know that too. The beauty of Vinny, I got to get used to that, is that you can make your own appointment. You can change it around within the electronic system. You're no longer dependent on calling 211 or standing online or whatever. So there's going to be some more autonomy in terms of getting that second dose in the way that you need to.
Right. So yeah, that's how I was going to answer. I think it will probably be some sort of the school district indicating that you couldn't get it through the closed pod and that ceased. And so you might be redirected to one of the public sites or the fixed sites, as we call them.
Yep.
Okay, we got about 10 minutes. Okay, it says, I can't find the nice FAQ sheet you showed at the beginning. Can you direct me to more where it is? We'll follow up with Cheryl, but I'm sure Cheryl will get those out to all the members of the association after this call, and we'll make them available also on the Medical Society site. So I think in the next couple of days, you'll have multiple ways, that they may choose to have it on the website, but we'll try to get these into your hands. And as we talked about, make them your own. We'll have both the MS Word and the PDF versions available, so you can take what's there, or if there's something else that you want to add to, please use your discretion on that. Can you explain the reason for no pre-med with ibuprofen or Tylenol prior to the vaccination? That's a great question. Go ahead.
Well, thanks for that. Not really, except I understand the rationale as described by CDC that they don't want to dampen any aspect of your immune system taking on the challenge, right? So they want you to be fully wide open to all the glorious aspects of immunity that are going to unfold for you, not just antibody, more than that. And we know that some of those drugs that dampen reactogenicity symptoms can also slow that down just a little bit. But I would like to say that it's okay to take after the fact. So if you need to treat those symptoms, it's okay to treat symptomatically, but probably don't pre-medicate before you go in.
That's right. Here's a question I'm definitely going to refer to you to, is how does a vaccine that has an EUA get to an approved vaccine fully by the FDA?
Yeah, they will start to watch the real life data. And actually, you're the one to answer that, aren't you, Dr. Potter? You have tons of experience in that arena, don't you?
Not as much as I'd like, but I think you're right. I'm not sure quite on the timetables of when we'll start to move this over. It's hard to tell because this we're dealing in timeframes that have been shrunken by previous experience. And so my guess is I was going to answer it the same way. When the data becomes available and it meets the FDA criteria. But I think in the mass dosing that has gone out, that data is going to be available sooner than later. My guess, I don't know, probably this summer, we'll start to see the mRNAs maybe approved finally.
That's what I would have guessed too. I don't want the FDA to be distracted at all, though, from doing an EUA for the next presentations of vaccines. So we'll see if their priority isn't getting as many vaccines out there as possible. So let's see how that plays out.
Good. Another staff is coming off a 10-day isolation. Are they able to get the vaccine the next day or soon after?
Yeah, great question. Thank you for an opportunity to remind you that if you are on quarantine or you are in isolation, we'd like you to delay. And that's an example of how Vinny is going to help you. You know, you can just reschedule. So please don't introduce the virus to our settings. We want people to see these points of distribution as safe. And so very much trying to accommodate a need to delay for a few days. Yes, as long as you're completed your isolation, 10 days usually, and you're feeling well enough, go ahead and take that vaccine. That's right. You may have some natural immunity for up to 90 days, but I think the easiest message for everyone is just take it as soon as you can. Let's get our population vaccinated with top of the line immunity.
Right. What was the thought of having Johnson fully vaccinated at 14 days versus 28 days? Makes sense. Just wondering.
I guess I need some clarification. Do you mean why did the company study the endpoints as they do in trials? That's what they call that, at 14 days and not 28? I'm not quite sure what you mean there.
I think what I saw is initially Johnson & Johnson had indicated that the Janssen vaccine would be fully effective after 28 days.
I see.
After the EUA, then it was reformulated to the 14-day level. So I think it's also to try to make it consistent.
I think that's right. I think there's consistency, and the fact that all of our vaccines generally do a maximum protection at about 14 days. You know, that's how we think about Tdap and flu and every other vaccine. So the consistency is probably important. We might buy a couple of extra percentage points of vaccine efficacy, but I think it's not worth deviating from a standard statement of when you are 14 days past completed vaccination series, whether 2 or 1. There's something very interesting happening with AstraZeneca, though. It seems like the longer you separate the 2-dose series, you may get better immunity, but we'll see if AstraZeneca ever comes to the US. They're having a lot of troubles these days.
Yeah, full disclosure, I was in the AstraZeneca trial here in New Hampshire in the fall.
Right.
Other than a greater affinity for bananas, I'm doing just fine. Thank you. And I do have antibodies. I'm not supposed to know that. I go out of state for a funeral, so I got myself tested. I do have antibodies. So.
Well, they're going to have to explain some stuff to the FDA. So again, I think Novavax is the next vaccine you're going to hear about, and we'll see.
Right. It has been said that we should not vaccinate all of our staff at once if there's multiple staff that they get sick and need to stay at home. May cause many people to be out. You have thoughts?
Yeah. you're exactly right that it may be worthwhile in a workplace setting to stagger or to recommend that these clinics happen on a Friday. The data are tight, that within 24 hours, you start to have your side effects. By 3 days, they're gone, and usually it's just a tight peak on and off. So if you can time your clinic for Friday, that's probably ideal. Nobody wants to lose their weekend. But not everybody has those bad side effects. The younger you are, the more likely you are to have those side effects. And then generally it's worse with the second dose, just again, not sugarcoating anything. So toward that end, specifically in your question, it might be worthwhile to stagger so that you don't have too many folks who feel they just can't come into work. So
yeah, the only closed pod that I've seen thus far is actually scheduled theirs for Saturday morning. So I think they're trying to take that.
Yeah, good.
Good. Also knowing that I think in this particular SAU that Monday for at least the high schools is not necessarily a heavy in-person day. So I think that will go into consideration. And it may not, it'll be up at every SAU. So I don't think that necessarily they'll be taking those kind of risks to put everyone potentially out on certain days. So they don't understand this.
There is that aspect. I'm glad you raised it. The other is that sometimes people have a fever or have symptoms that might look like COVID itself. And so this runs the risk of being somewhat confusing when you're doing your screening. So being aware of what we expect with regards to reactogenicity and timing is going to be pretty important so that you don't inadvertently screen out people who don't need to be, or on the flip side, let in a patient who actually was incubating COVID around the time they got their vaccine. So an awkward space for sure.
There is one of the FAQs does address this issue. So if you're not able to kind of put this together, you can kind of go back as a reference and articulates essentially what Dr. Tully just articulated. So you have a reference there to kind of go back through. If a staff member has had COVID recently, do they take both Moderna doses?
Looks like you're paying attention to some of the hypotheses out there. That's what they are, is that it looks like if somebody has documented COVID and they take one of the mRNA vaccines, all indications of immunity go really, really, really high. So there's like a prime from having disease, and then the second vaccine really shoots it up. That's a hypothesis that's a public health strategy. We don't know how durable that immunity is or so. And right now we're still saying, please do take both doses, be complete, do it like you're supposed to do. But we'll see what time tells us over time, how this emerges.
Right. Another good question here. Do people experience increased side effects if they've already had COVID, and why?
I think it's quite analogous to the reality that the second dose tends to have higher side effect percentage and severity than the first dose, is because your immune system is all a titter, it's seen this thing before. And so that whether it's from a first dose or from having actual disease, it revs up really efficiently when that happens. So it's probably more severe, but that data I haven't seen in peer review literature. I've heard it anecdotally, and it makes intuitive sense to me. So I'll just say that.
Okay, here's a good, I listened to a webinar around an experimental oral COVID-19 vaccine. In the discussion, if it works, the distribution and administering will be easier. Are you familiar with this?
Simple answer, no. I am aware that they have an analogous prototype for intranasal, like we have for the flu shot, right? LAIV formulation of flu. That makes sense to me because it's a respiratory virus. You want to create the immunity, especially at the mucosal surfaces where the virus gets in. I've not heard of an oral yet, but I'll keep my eye out for that.
We are receiving questions related to CDC newly fully vaccinated individuals' benefits of gathering with other vaccinated individuals. Looking forward to clear recommendations related to school staff.
Yeah, so I'd like to make a couple of statements about that. I know we're in dwindling moments. Should I take it on? Because this is a question I'm getting in big numbers. So if you want to hang in a couple extra minutes, I will actually share my screen from our partner call this morning. Oh, I'm going to show it to you in the wrong mode, if you will, and pick and choose some slides. First of all, these CDC guidances are clearly intended for persons who are in home settings, not healthcare, not businesses. So I think schools right off the bat are excluded. It applies only, and let me check, do you see my slides, Dr. Potter? Okay, just to be sure, applies only to non-healthcare settings and private settings. Yeah, so this means that within those private settings, a graphic like this helps people to understand how being fully vaccinated, 14 days past either the one Johnson & Johnson or 14 days past your second mRNA vaccine, can now begin to get back to some semblance of normal life. So, this requires a little bit of explanation, at least it did to me. The green dots are people who are fully vaccinated. The orange dots are people who are not vaccinated, but they are at low risk for severe outcomes from COVID-19. So you have to know what those people are, who those people are. In this graphic, the orange circles that are uncolored in are people who are unvaccinated but at high risk for bad outcome. And then the dashed ones are people who are not vaccinated at high risk, but not at the home at the time. So either grandpa who lives down the street or somebody who's out shopping, but is somebody who would have a bad outcome if they were to be exposed. So this kind of gives you the sense that really the only changes in our routine are for those from a single household, fully vaccinated, can visit others from a single household who are fully vaccinated. You don't need to wear a mask. You can have physical contact. You can start to feel like we're on the downside of this. The other option is if you're fully vaccinated in one household, you in another household where people are not vaccinated, but they are at low risk should there happen to be breakthrough disease. Everything else is still with the community mitigation. So I just highlight this for you. And the most important response to your question, I think, is that this does not apply to businesses, but only these, idealized homes. So I guess the house has to have a chimney. Just kidding. So it's really a private setting, and so it doesn't matter. I can't help but see this next one. Teacher informed me that Governor Sununu lifted the travel quarantine, made it a suggestion but not mandatory. Is it accurate? Yes, it is. So we were also quite surprised by this, but just to let you know, we will adapt all of our guidances to reflect the language that he is electing within this. I would say we still would discourage people from traveling because of the emergence of these variants. Okay, so Florida is a hotbed of variants, for example, and I'm a little concerned everybody's going to go down for spring break now. So you can still privately require quarantine if you choose to, and I know many healthcare settings will continue to do that. So we're adjusting. Our guidance will come to you soon and be consistent and accessible, but this is all a reflection of the great work that you're doing, not only in community mitigation, keeping our kids safe in schools, but also by accessing this vaccine and by being that ambassador of vaccine.
Great. Dr. Talbot, thank you very much as always. We very much, Cheryl, we very much appreciate the opportunity to come talk with New Hampshire school nurses. And I will just say, go out there and do good. It's the shortest answer I can give you. If you have further questions, we'll be in touch with Cheryl and others through the leadership, and we'll try to make sure that you have the presentation that we gave to begin with, and the other materials, the FAQs, as soon as possible. Sure.
Great.
Great. Thank you both so much. Dr. Potter, it was wonderful to meet you. Dr. Talbot, it's always an honor to listen to you. It's truly a treat. We really are your groupies. Just so you know, if you're ever having a rough day, you can just turn to the school nurses. We're right there for you.
It really
Thank
makes me feel good. Thank you.
You're welcome. You all do good work. I call you and Dr. Daly and Dr. Chan the Triple Crown of New Hampshire, just so you know. I do.
I'll pass it on.
Yeah, please do. We truly appreciate it because you guys have yet to have a break that, and if you have, you hide it well. But thank you all for attending. We will absolutely get those FAQs out to you, and have a great evening.
Bye-bye, everybody. Stay safe. Good luck. Enjoy your vaccine.
Thank you.